this is a very important topic that what insulin we're going to choose when treating a diabetic patient. But before that, I must say this is not just an unilateral CME. I want to clear all the clouds. If you have any problem in diabetic patients dealing with their oral tablets, oral hypoglycemics, what are lifestyle modifications, what insulin, where to use insulin. I'm not going into detail because that's going to take a couple of weeks maybe. So I'm going to start with insulin first, and one topic I've been given that we are spoiled with choices and which insulin, why analog. That's the first issues. So we're going to talk about it, and then if you have any questions, I'm always there if you want to continue. So you cannot start a topic without knowing what bulk of burden we have on our shoulder. Because this is a global projections for the diabetes epidemic. You can see in 2010, 2030, we're going to be the diabetic capital in the whole world, and especially the Southeast Asia. And you can see how it's spreading. It's going every day, and it's going to be a major health issue in coming time. Yes, you can call this an epidemic because you can see how these things are changing. And it started in 2011 and 2030. What the expectations is, even in the developed world, you can see that how it's going up. And I don't want to go to the figures. You can see that it's jumping. Even in China, from 90 millions to 129 millions. India, I must quote, 61 millions in 2011, and we are expecting it's going to be 101 million. So you can see that another 40 millions is going to be added to diabetes. And so cannot say that I deal with medicine and I don't know which one to start with or how to deal with diabetes. And that's what I've talked about. See that the red lines is 61 to 101. Diabetes and pre-diabetics in urban and rural area. You can see this study which is done sometime back. And prevalence of diabetes and pre-diabetics, impaired fasting glucose and impaired glucose tolerance in urban and rural areas. Phase 1 results from the Indian Council of Medical Research. This is absolutely an Indian statistics. Nadia, diabetes, ICMR, and this study estimate translates to 62.4 million individuals with diabetes and 77.2 million with pre-diabetes. And if you read diabetes, you will say that more than half of the people who are pre-diabetic is going to have diabetes. So you can see the figure is astronomical figure. Now we're going to jump to the topic, and you can see the limitations of the human insulin, which we've been using for a long time. We used to use the animal insulin party, which has become a poor quality of insulin. We used to get a lot of antibodies against it, so we switched over to human insulin, and we thought we got the golden one. But we didn't. The human insulin has got problem with the absorption. It's a suboptimal postprandial glycemic control because you get a delayed absorption, and you know that in diabetes you get a very high sugar once you take a meal. So this slowly absorption sometimes becomes a problem. And it's an inconvenient injections. You have to take at least half an hour before the meal. So you can see that when the meal will be served, you have to know clockwise and who is going to serve it and whether it is going to come in time and things. Socially, sometimes it becomes very difficult because you can take the insulin and the food might not arrive. So it's a big problem. Longer duration of action. Now, why longer duration of action is a problem? Because you can see in diabetes you get a postprandial hyperglycemia which goes very high and then it goes down. Whereas you will have a longer duration action with the human insulin. And that's why after 4 or 5 hours before the next meal, you can always get some hypoglycemic episodes. Or maybe it's not minimal sugar going down and feel uncomfortable. Lower quality of life. Injections and meals must be planned, so the quality of life is going down because you can't do your predictable work, your planning work and things like that. More variable, it's unpredictable because the glucose value and the insulin, that rational to choose what units, how much, the quantity, sometimes become very erratic because there are so much subjective variations of insulin requirement, especially with human insulin, because of the slow absorption of insulin. So you can see this. The rate one is the physiological insulin profile. You get a basal component and you get a meal-related piece. So God has given an islet cells which is secreting insulin throughout in a very unique fashion. But when we have insulin prepared, we're giving 3 injections. It's the minimum we try to give so that you get a good quality of life, so that you don't have to think of multiple injections and things. There, we are compromising in the quality control. And you can see the red line which goes up and down, that is the insulin secretions with the meal. When the meal comes, when you take the meal and the blood sugar surges up and you get a lot of insulin coming from the islet cells, which never happens in mixed up. So mixed up, what happens, you can give the insulin, it starts a little late, you can see the blue line and the red line is the physiological and the blue line is the mixed up. And it comes a little late and it goes up, but it doesn't reach the peak. So you get a postprandial hyperglycemia still left, and it goes slowly curves down. So you have a high insulin still left when the food is already assimilated and the blood sugar has gone down, the insulin is still there. So it's really practically very difficult. So this is the period of unwanted hyperglycemia. So you get still left with some sugar after the meal. Now if you want to correct it, then you can see that even the blue line going down will be again up. And there, the chances of real hypoglycemia would be high. So period of unwanted hypoglycemia, this is the one. So period of unwanted hyperglycemia in the initial phase and period of unwanted hypoglycemia in the later phase. So, so human mixture, when you start giving, we've been giving it for such a long time, and we didn't have choice, and we didn't have, so we used to face a lot of problems. Still, people who are the best self-monitored people, still their hemoglobin A1C is high because of this increased hyperglycemia and the chances of hypoglycemia. This is a balance which we could never do. Insulin analog, because this is after a lot of research, the scientists who wanted to match the physiological doses, they try to have a design so that we can mimic the physiological doses of insulin closely. And this is called modified or modern insulins or newer insulins. The molecules differ by one or few amino acids which is put in the primary structure so that the quality of the insulin can be changed, and this is what is done. We developed a more physiological replacement after subcutaneous injections than human insulin, and made possible by the advent of biotechnology, our DNA technology, and provide more optimal time action profile. So what are the insulin analogs advantages? Addressing the limitation with the human insulin. You can see that mimics more. I wouldn't say mimics the physiological insulin secretion. The word more is absent here. So it mimics more, but still, in some of the very resistant hyperglycemic and the people who are notorious to take care of the sugars with the multiple injections, we still use insulin pump. And if it would have been this analog would take care of everything, we wouldn't have the pump. So, but it mimics more of physiological insulin secretion, better time actions profile when they use insulin, and have more predictable actions, superior PPG reduction, that's the postprandial sugar reductions, more cardiovascular benefit, because it's been proved now in diabetes that a postprandial sugar is directly related with CV mortality. So PPG is directly related with the CV mortality. So you can see that superior PPG reductions and more cardiac safety. More safety, less hypoglycemia, the chances of sugar going down and going, less undesired weight gain. Why? Because again, to titrate this sugar, even though we were giving human insulin in doses which would have taken care of it, that would have kept the insulin level up all through other times where sugar is not there, which, as you know, insulin is nothing but more of a growth hormone-like activity, so that increases the weight and this causes weight gain. So if you can have a more physiological, then the chances of weight gain will be less. Meantime flexibility is very good. In fact, we have this analog short-acting insulins to type 1 diabetics, where they keep their pains in their pulses, and they can actually have a carbohydrate counting, which we teach them that how to know when a pizza comes, how much carbohydrate will be there, or dosa. So they can calculate the carbohydrate, that's called carbohydrate counting, and they can use the insulin just before the meal to take care of the meal charges. Insulin analog classifications, again, like all other insulins, divided into two parts. One is a rapid-acting insulin and a long-acting insulin. Now, long-acting insulin can be divided into intermediate and long-acting, but they are actually more than 6 hours, so they should be called long-acting. And you can have a combination of the two, is called a premix. Why is it called premix? Because you have a combinations done by the companies. So it comes in a mixed form, so it's called a premix. Rapid-acting insulin, there are three varieties. As you can see, Aspart, Listro, and Glucid. All three is available in India now. Novorapid, Listro, and Efidra, which is Glucid. Long-acting insulin Detamir and insulin Glargine, those are available. And you can see the biphasic insulin, which is the Novomix, and Listro mix is 25. As you can see, that one is, when it's a Listro, it's 75-25, Novomix is 37. Rapid-acting insulin analog, you can see where they replace the proteins and see is there a different color, and this is the insulin molecule. You can see how they have changed the molecules, how clever these people to change this, just to put amino acids and make a better one. Now, what's the difference? This is very important. What's the difference? You can see as better pharmacokinetics, insulin aspirate by regular human insulin. Onset of action regular human insulin is 30 to 60 minutes. That's why we ask the patients to take at least half an hour before the meal. And where insulin aspirate would be 10 to 15 minutes. So you can always get it when the food comes and you can give it. Because it's usually 5 to 6 minutes or 10 minutes it takes the meal to go there, and another 5-6 minutes before the sugar starts going up in the blood. So 10-15 minutes is good enough. When the sugar will be in the blood, then it will start acting. Duration actions, again, you see that the normal insulin, human insulin, what you regular human insulin, it takes 6 to 8 hours, almost close to an intermediate insulin level, which we don't want, because the pre-meal time, you'll be feeling very hungry or you have hypoglycemic attacks. Whereas insulin aspirate is only 3 to 5 hours. Effectively, is close to 4 hours. So twice as rapid onset and as high peak. You can see the differences here. That the crossover study, single dose study in healthy volunteers. You can see this. The insulin aspart is in the orange line, and the regular human insulin is in the blue line. And you can see this how the peak is going up and how it's closing down within 300 minutes, almost 240 to 280 minutes. Whereas in regular insulin, you can see it is going up. The peak is not there, even not close to the aspart. It is quite low. So post-prandial sugar correction is a little less, and you can see this graph is is quite slow, and it's going down. It's going down quite slowly and gradually it's going down. So it's still up here with the chances of hypoglycemia. mealtime flexibility, you can see this difference, and you can see as you can see this high sugar is high 0 to 5 minutes, insulin aspart is 0 to 5. You can see this when you have a sugar which is going off, high sugar, and how the insulin is acting here. And this is the test mill we've given. And we have actually, this is a plasma focus. It's a European study, so it's in the minimum. And you can always add 18, multiply 18 with this, and this is going to come to milligram. So you can see up to 13, 14, then it's 180, so it's going to be 240 and things. And you can see this how the test mill is going up, and how the test mill after that, if you have given an insulin, the production is this much. And it's close to the just before and after food. It's close to the physiological actions of normal insulin we have. See the difference between the insulin aspart and human insulin. So you can see this, the blood glucose when after giving insulin aspart, it's going up in going off. This difference is with the insulin, regular insulin, we still have a quite high postprandial blood sugar reduction with the insulin, and it's close to normal on 6 is going to be around 90 to 100. See with this is the European trial. The Americans are more rigorous, so you can see the sugar is quite close compared to this. So the pre-prandial increment and the mean prandial increment in the mean increase in blood glucose from pre-meal to 90 minutes of post-meal. You can see the difference in a bar graph quite close at how this is compared to the regular insulin. Again, this is a European trial and North American trial is close to insulin aspart in human insulin. It shows the hemoglobin A1C, and you can see the hemoglobin A1C is close to quite low compared to the hemoglobin A1C on human insulin. So as you know, the human hemoglobin A1C has become one of the most important predictor of sugar control. So you can see this, the difference between the human insulin and the aspart is quite good. The chances of hypoglycemia, you see the total hypoglycemia is much more with the regular insulin, much less with this. And the nocturnal hypoglycemia, which is the worst bit, because this is a very unpleasant one for the diabetic to get up in the middle of night feeling very unwell and sweaty and vomiting and things, is much less with aspart. So you can see the difference, 72% reduction, which of normal nocturnal hypoglycemia. So insulin aspart insulin analog of choice in special situations where you do group, and it is already approved for children above 2 years. Of course, we are talking of IDD here, or type 1 diabetes, and safe for use in patients with liver and kidney dysfunction, which previously, even when I did my MD, people said no, stick to only your regular insulin, human insulin, and you cannot use any other things. The most interesting bit is that we can use it now in insulin pump. So you can use it in insulin pump. Well, basically, how the insulin pump differs from regular insulin is practically we haven't got much of a trial. As you know that if you had a tablets working for 24 hours, then if somebody brings a slow release preparation for 24 hours, I don't find any practical difference between the two, because the plasma half-life of a drug of 24 hours and bringing it in a slow release preparation 24 hours makes the same thing, provided that after taking for 24 hours after meal you get a very high level of blood level which could be having more side effects into that, where slow disease progression will have a moderate level of plasma level, which reduces the things. So even now, where we can prefer to use an insulin pump, we can use aspart, but that we can use with the human activator. Again, the difference is if you stop the human activator on a pump, think of that a patient who's got very high sugar with a DK or a stroke or an MI or a sepsis and things, and you use the human activator, and the patients would need to go to the OT, or patients has got a hypoglycemia, you can stop it. Stop the insulin pump. But the action will last for 6 hours. As I've already shown you the graph. But if you stop it on aspart, it probably will be only 3 hours. So the chances of stopping it and then waiting for 4 hours till the blood sugar come up to again 300, 400 for which you have prescribed, you would be having 6 hours time, well in insulin aspart. The second thing is the subcutaneous pump when you use for someone. You can always use this because that will be close to mimic insulin, physiological insulin from islets. Ideal for managing hyperglycemic emergencies, so you can always use. In fact, one of my postgraduate students had done for his thesis these things. I actually did a two-arm trial where we had given insulin pump to a patient who is in ICU, and where pump facilities are there, which can be taken care by the trained nurses, and patients who had so-called hyperglycemic emergencies but can't afford an ICU. There we had given multiple injections with short-acting ones, and compared between the two how the management is close enough. So you can actually have people who can't afford an insulin pump. You can manage the hypoglycemic emergencies if you use it very judiciously.